feel like we are friends, family. We'll have to spend the time together no matter what. And Professor Park is an emeritus professor at Auto Department at Yonsei University. He is the one who created the level arm mechanics and published the article here and there, and also he is the first one who organized the World Implant Orthodontic Conference, and it's still active, very active. This year, next month, the WIOC conference will be held in Maringá City, Brazil, from August 7th to August 8th. So this will be annual conference. So if you want to learn a lot about the mini-screw mechanics techniques and theory and reality, and that's the main conference, more than AAO meeting for sure. This is the one conference you have to go and attend. All right? And okay, so let me invite Professor Young Choi Park and give him a big hand.
Thank you very much, Dr. Lee. Good afternoon. I'm Young Choi Park. As you see, the longest faculty member in this department. I'd like to express my warmest welcome to all of you. To Yonsei University. And I hope you can all have a great and enjoyable time during your stay in Korea. As Dr. Lee mentioned, this is the first executive members picture at first WIOC in Seoul, Korea, back in 2008. Many familiar faces you can see. And this is 2017 in WIOC in Kobe, Japan. Now Giuliano is the president of this meeting from Italy. This is last year we had a 24th KAO, Korean Association of Orthodontists, and the WIOC combined joint meeting here in South Korea. Okay? So WIOC has an annual meeting. It goes all around the world and come back last year to Seoul, Korea. This is the executive members of KAO. Now, Dr. Bang is the president of Korean Association of Orthodontists. And this is APOC in 2018. I think I was designated as an honorary member of APOC in 2018. This is Philippines. Okay? They gave me honor as a present, but I let them free. This is my last AO meeting that I present and have a lecture. This is the faculty of our department who visited Washington, D.C. It was my title at the 2018 AO. Okay, I'd like to introduce some books for the lingual orthodontics, and this is the first book written in English and French, and also Portuguese. It has a lot of translations. It's almost the first book regarding the mini implants. And in Dr. Ravinanda also had a book in TED, and I wrote the chapter 6 for the biomechanical principles in screw-driven orthodontics in the chapter. In Graeber textbook 2011, mini screw was first joined for the general chapter. So we wrote the chapter 12, and the 6th edition was also published. And this year, the new edition of Graeber textbook will be coming, and we also wrote the chapter about biomechanical constellation and TED. In 2015, I wrote some books about lingual orthodontics with many authors, and also from Japan, Takemoto joined the chapter. Okay, let's get started. My presentation. Lever arm mechanics in extraction treatment. Most common mistakes during space closure in orthodontics is to lose control the axial inclination of anterior teeth. If you look at this patient, before treatment, the upper incisor was 1114 degree, and it was changed to 95 degree after treatment. Too much lingual tipping of anterior teeth had taken place. If we lose to control the whole system during space closure, tipping, vertical bowing, and anchorage loss take place. Like this patient, tipping, and also vertical bowing take place lingually or labially too. To prevent these side effects and for the efficient tooth movement, we introduced lever arm mechanics in lingual orthodontics back in 2000. I will explain it in more detail. The principle of the lever arm mechanics is desired teeth movement is obtained by adjusting the length of lever arm. This is the lever arm, and the line of force. The green color shows the line of force. Okay. By changing the line of force, we can get the tooth movement that we desire. Okay, this too is an equivalent for system. If we want to translate, in other words, bodily movement of this teeth, we give the force to the center of resistance of the teeth. Then it will go translation. But unfortunately and practically, we should put a force on the bracket level. So with the force and moment can get the same movement for the translation. So this too is an equivalent force system. So especially in lingual, the bracket side is there's a moment arm should be created during space closure. So it's very easy to lose control and get the lingual tipping. So we call it uncontrolled tipping. So when you use the lever arm mechanics, the red dot means the center of resistance, and if we move the force to the center of resistance, it will translate. Okay. Let me explain line of force in more detail. During the extraction space close, if the line of force is at the crown level, okay, it will tip like this. It will take place. But if we make put a lever arm here and make the line of force to the center of resistance, translation will take place. And if we use the mini screw here, so we can get absolute anchorage on the posterior side. This is the first generation design of lever arm. This is the lever arm, anterior lever arm, and also the posterior lever arm. At the time, the mini screw was used back to only 2000. There's no mini screw here. So the main principle is saying that the desired force is passing through the center of resistance of anterior segment and posterior segment. It will translate. Okay? This is the second generation of lever arm design. The connecting bar is soldered for the rigidity of this lever arm. And mini screw was used for the anchorage and point of force application to the upward side. I think you should memorize this picture. This is the finite element method study. The center of resistance was determined. The blue dot in A is the center of resistance of 4 incisor, 4 maxillary incisor. And B is the center of resistance of 6 anterior teeth. And blue dot C is the center of resistance of the 4 maxillary dentition. Okay? So if we want to move this anterior, 6 anterior teeth translation, then we need the force, line of force passing through the center of resistance. Yeah? So I think you should memorize this picture. There are 2 types of lever arm mechanics, which is segmented tie, segment anterior teeth together and posterior teeth together. Just imagine there's a 1 anterior teeth with 6 roots. Okay? And posterior teeth is the same principle. Okay? So this segmentation method, I got some idea from Charlie Burston from the University of Connecticut, who was my mentor. And the sliding method, it has a friction between the bracket and the arch wire. So, but it slides through the bracket slot. Okay? I will explain one by one in more detail. There's several types of continuous arch wire sliding method, and this is a segmentation method combined with mini screw. Okay? 6 anterior segment will retract translatorly. So mini screw on the palatal side, palatal floor, or mini screw on the mid palate. You can use depending upon the patient situation. So in sliding method, it's very safe and easy to apply, and we can control moment force ratio by controlling the length of the lever. And the disadvantage is friction, and so it's difficult for anchorage control. But it can be solved by using the mini screw. This is a 23-year lady, has some protrusion of lips and teeth, and minor crowding. So for her treatment, this is VTO for her treatment. So for first bicuspid extraction was decided for her. This is the 6 months for after alignment and leveling. The anterior segment is going back. Retraction is started with palatal mini screw. Okay? And in this stage, you should use a rigid wire, so which is 016/022 stainless steel wire. So to determine the center of resistance of 6 anterior teeth, we have this figure, 40 millimeters from the incisor edge to the center of resistance. So if we give the force to here it will translate, but force to this area, it will have controlled tipping. Okay? Because initially the upper incisor tipped too far to the lateral side. After the controlled tipping, the axis was almost normal. So then we decided to move teeth with translation. Change the elastic point from here to here, okay, the downside. Then it will go to this way. This is the design of the H-shaped lever arm, and the length of the lever arm is 20 millimeters, and this connecting bar is soldered together for the rigidity of the lever arm. Please take a picture of this picture. Take a picture of this slide. Okay? After 18 months, space closure was finished. So here's at 20 months, treatment was finished. Good paralleling we can get, and before and after comparison. Comparison of before and after. Okay. So VTO and rear superimposition before and after. So next case is a 24-year-old lady. She's a class 2. And this is non-extraction case. So we want total distalization and intrusion because she had deep overbite in the front side. Okay? So this is the level arm design again. And apply the elastomeric chain from this hook to the mini screw. So wide opening and the class 1 molar and canine key was established. This is before and after. Almost within 1 year, treatment was finished. This is a superimposition. Intrusion and distalization of whole maxillary dentition will take place. Before and after. Okay. Now let me show you the segmentation method, which is from anterior segment and posterior segment. There's no friction between arch wire and bracket. Okay? And accurate tooth movement is possible by controlling the length and the position of the mini screw. But you should do it very carefully because if you keep the force to the wrong direction, it will go three-dimensionally. So first you should start with sliding method. Then if you have some experience, then I'd like to recommend to go change to the segmentation method. She was a dental student. Chief concern was the protrusion of the tooth and lips, and floor by cuspid was extracted. Again, this is the center of resistance of 6 anterior teeth. We can figure out the lateral, exactly the 45 set is more better. And the PA set, you can figure out the center of resistance and switch it to the model. And you can design the appliance like this. So there's many application points, frontally and backside. At the time, there's no mini screw. So space close was finished. Lingually, in lower arch, we also used some Lego arm at the first time, but nowadays we seldom use it. Before and after space closure, almost 20 months treatment was finished. So we can get control the moment force ratio, and we can get translatory intrusion of different segments before and after. And as I mentioned, if we use excuse me. Sliding method or segmentation method with mini screw, we can get absolute anchorage and we can get more effective force system. This is another segmentation method. There's no bracket, just bend the wire passively and bond it to the lingual surface of the teeth, and another 0.6 millimeter stainless steel wire was soldered for the lever arm here. So it is connected with the palatal mini screw. Our chief concern was the crowding and protrusion. We had a premolar extraction, and this is the lever arm design. Okay. So if you want a controlled tipping, you can apply a forced elastomeric chain here. If you want translation, you can apply an elastomeric chain here. Okay. This is a lower arch. Lower arch also we had this kind of lever arm made by the thermoplastic material. We call it aesthetic lever arm. Okay. So you can aesthetic lever arm. Okay, space closure was studied. We can figure out the length of the lever arm and point of force application. 9 months. Take a look at the aesthetic lever arm, which is bonded directly to the teeth surface. Okay. After 2 years, treatment was finished. Comparison of before and after. Translatory retraction was performed on both arch. So the advantage of lever arm mechanics is effective anchorage control is possible. So you can control moment force ratio by controlling the application force application point. Okay? And easy to reactivation. Every time after we set the final arch wire, every time the patient comes, the only thing we should do is changing the elastomeric chain every 4 to 6 weeks. Okay?
4 to 6 weeks.
Very simple. This is midline shift. Midline was off to the right side. Okay. And we need type A anchorage for this side. This is another modification of segmentation method. If we guess, evaluate the center of resistance is around here of 6 anterior teeth transversely. Okay. If you apply force to here, we had a unilateral premolar extraction on this patient to correct the midline shift and the retraction. So upper and lower right first premolar was extracted only. Left side there is no extraction. Okay? So if you apply force to this direction, it will go and rotate like this. So we can play with 3-dimensionally for this segmentation method. Okay? So this is our treatment midline in here, and after we get the treatment, we want to get the treatment midline. So this is treatment was finished. Only one side premolar extraction. Midline was won. And the advantage of lingual orthodontics, there is no limitation for lever arm length because we can use the palatal side. But radial side, there is a short vestibular depth. So we have some restrictions of the length of the level arm. So this is the example of the radial side. You can get short vestibular depth. There's some limitation to lengthening the length. So in this case, we will add some moment by make the lingual root top on the main archway. This place is near within 30 minutes, so you should go and visit. Not every case is treated as we want, as we designed. Okay, I'm sorry. So she was also the anterior protrusion case, and initially the upper incisor was 110, very labial version. She was 4 by cuspid extraction case. And with this design, the lever arm was not too long. So there's a center of resistance here. The force goes beneath the center of resistance. The uncontrolled tipping of front teeth took place. According to Dr. Crickmore, there's a bracket slot clearance is almost 12 degrees between if we use the 016-022 wire and on the 018 slot, 018 by 025 slot, there's a bracket slot clearance of about 12 degrees. So we should determine freedom, clearance of the wire and bracket clearance. Okay? So if we got the normal degree, we lose the tipping. Okay? Now back to her case. After 10 months, her incisor teeth had uncontrolled tipping here from 112 to change to 91. So there's some side effect happened. So to correct that, we remove the bracket and put a rigid wire, bond the rigid wire to here, and make a long, extra long lever arm. Okay? With 0.8 millimeter stainless steel wire. So the line of force goes beneath the center of resistance. It will take root movement. Okay? After correction of the root of anterior, axial inclination of anterior teeth, from initial, after 10 months and after 22 months, it changed from the 91 to 100. So we can recover the lingual root top by the extra long lever arm. This is superimposition. So extra long lever arm, the line of force, we can change the line of force above the center of resistance. Another way to correct the axial inclination is add lingual root top on the archway, okay? As you all know. This is before and after the 4 bicuspid extraction case. The lingual root talk took place here by giving the extra long lever arm. Okay? Why? How long the length of lever arm? According to our study, with the length of 20 millimeters from here to here, we can get a translation. Okay? By the FA finite element study, in my department, we had length of 20 millimeters, get the result that we want. And the minuscule position is palatal slope and mid palatal suture. There's many differences, some differences. And the length of lever arm from 0, 10, 20. So, in summary, in conclusion, long lever arm about 20 millimeters, bodily movement of upper incisor can take place with palatal slope, minuscule. And transversely, imagine that this is a 6th anterior teeth. If we give the force to this direction, there's some lateral bowing will take place here. Okay? We go more closely. Deformation of the main arch wire. Mesh represent before deformation of teeth, and colored to blue is after deformation. So the lateral flaring can take place at canine area. So to reduce this lateral displacement, we can get the connecting bar here. This is to prevent lateral displacement. This is the reason that we need a connecting bar. Okay. This is connecting bar. There's a many configuration of tooth movement depending upon the bracket position, palatal slope, and mid-palatal screw. Dr. Kijun Lee will explain it in more detail. Okay, let's talk about the minuscule implantation site. We choose mid-palatal slope in many patients. According to our cadaver study, we declassified and sectioned and measured 23 adult cadaver. We sectioned here between P2 and first molar. The cross-sectional space view of this area. And this is buccal side and this is palatal. The cortical bone thickness is thicker than on the palatal side than buccal side. Okay? It's about 1.5 to 2 millimeters on palatal and 1.0 to 1.5 in buccal side. Okay? And socket thickness on this area is thicker in palatal, almost 3.0 to 3.5 millimeter thickness. That's why we should use the longer screw on the palatal side. This is the direction of the oblique injection is recommended on the palatal side, and the angulation should be parallel to the connect surface, not this direction. Okay? It will give a root damage. And we can get more cortical bone contact through this oblique injection, and we can escape the thick soft tissue. One more thing we should remember is the anatomy and the location of the great palatine foramen here on palatal side. So great palatine artery and nerve located about 12 millimeters from the cervical CJ. So not go up to the 12 millimeters from the cervical CJ. Okay? When you implant the mini screw on the palatal side. So on the palatal side, we use long neck tie because the soft tissue is thick. The length is 9 millimeters. 1A3 or 9 means soft tissue is 3 millimeters. Soft tissue color is 3 millimeters. And mini screw diameter 1.8 millimeters. So we call it 1A309. 9 means the total length from here to here. This is 3 millimeters, this is 6 millimeters. So we use long neck type here. And with palate, we use regular 7 millimeter length. But depending upon the authors or textbook, there's various type and various lengths and various thickness used. They are stable. There's no loosening. It's okay, but I prefer this kind. This is the standard type. Is 7 millimeter. And this is 9 millimeter. And the head is like an 022 size. We can attach some 022 by 025 wire in here or there. Mostly, I use only these two types. Mini screws. And we don't need many inventories. Okay? So only screw. This one is a long neck type. This one is a standard type. And use the driver tip is a regular size. And on the mid palate, we should use the long driver tip. Okay? Go into the mid palate. Several kind of engine. Okay, I will skip this slide. This is another one who use H-shaped leg arm. Since I have to talk about the lingual application, but from now on, I will talk about labial application, which you will be more interested. We can use level arm in the labial side here. She was class 2, division 1 with deep overbite and overjet chip complaint. So, treatment plan was extraction only upper post-premolar. We can make a level arm with 018 by 025 SS wire. And the application point was soldered here on both sides. This is segmentation time. Okay? Before space closure, screw was implanted between 5 and 6. After treatment, super class 2 molar relationship was attained. Before and after superimposition. Okay. Another case with a lot of crowding. This is also the 4 bicuspid extraction case. We use mid-palatal mini screw for the anchorage on molar side. And Burston one-piece intrusion arch was engaged too for the pipe opening. This is another lever arm mechanics for the space closure. Okay? You can figure out the line of force. Sometimes we can add some lingual toe because this lever arm size is relatively short compared to the lingual side. Okay. 16 months treatment was finished. Superimposition. This is a deep bite case. What concern was the protrusion of a frontis and the gummy smile. Lower one incisor was missing in this her. Shows deep overbite and overjet here. And her treatment plan was also upper premolar extraction. In terms of gummy smile, it from cervical margin to the gingival showing gingival display amount is over 5 millimeters is a surgery case. It's called a vertical maxillary excess, like her. But she was inflamed for the surgery, so we tried it by only orthodontic means. You can see the intrusion in the front side with the mini screw, and also the lever arm is attached with clippable hook. Okay? It's very simple, not need to solder. To the posterior mini screw. With intrusive retraction will take place here. Treatment was finished. It's 31 months, but the gingival contour is not looks good, so we have some gingival surgery here. Again, the molar relationship was before was class 2, and after was a super class 2. Okay? That's good. For her function. Comparison of before and after. We can achieve the deep overbite. We get normal overbite and change the gummy smile. Can you see the intrusion and retraction of upper incisor? Okay. I will show you only 2 cases. Okay? actress in Korea. And this case was published in 2007 AJO. Aesthetic segmental retraction of maxillary anterior teeth with a palatal appliance and orthodontic mini implant. I used the lever arm and mini screw on this patient. Okay? Let's see together. Her chief concern was the protruded lips and teeth here. And this is the initial, and there's a lot of crowding here in the lower arch. Treatment plan was again for bicuspid extraction. And this is the design of lingually controlled tipping. Is our design, our treatment plan. I put mid-palatal mini screw on 2 mini screw was implanted here. And connected together with the lingual sheath and 0.9 SS wire and bonded with direct resin. And we can determine the line of force for the type of tooth movement that we want on her patient. The position of senile resistance and determine the line of force here. Then we can get controlled tipping of the 6 front teeth. Posteriorly, we extended the wire from the mini screw that we can get lower the point of force application. And labially, we use aesthetic lever arm. 4 aesthetic lever arm were bonded here, connected with the mini screw. At the first time, we used the FRC, fiber reinforced composite here. After space closure with the lever arm and mini screw on the mid-palatal side, space closure was almost finished at 11 months. Then we switched to the ceramic bracket for the detailing. "16 months later, treatment was finished. The thickness of the mid-palate was about 6 to 7 millimeters in the palatal side. But if we off the center is very thick, 6 to 7 millimeters. But if we off the center from 3 to 5 millimeters, there's a major cavity, very thin. So you should be very careful to determine the thickness of the palatal bone. So if possible, the mid-palatal mini screw should be located on the mid-palate area. Okay? So thickness in the lateral side is very, very thin. Okay? Before and after, root paralleling was achieved. Okay, next is the last case. This is superimposition, and this is the last case. It was also in AJODO in 2009. Combined use of mini screw and clear appliance for the treatment of bialveolar protrusion without conventional bracket. This is an extraction case. We used level arm principle, and we can finish it without bracket. Okay? Let's see what happens. This is our treatment plan. Okay? Almost translatory controlled fitting is needed. At the beginning, skeletally class 2 with anterior open bile and protrusion, 4 bicuspid extraction side. This is eccentric level arm. For the eccentric space closure, lingually, the 6 anterior teeth were splinted together with the wire, and the position of the meniscus was determined for the desired tooth movement. And the labial side, we can make the eccentric level arm like this by cutting out the surface of the thermoplastic sheet here, like Duran, based on the shape of the lever arm with scissors. Very simple. And the thickness of the thermoplastic sheet should be 1.0 millimeters, recommended for the stiffness of the lever arm. There's a different kind of thermoplastic materials. You can use it, anything you like. So determine the line of force by the length of a eccentric lever arm and the position of the meniscus. So here's the eccentric lever arm on upper and lower. Space closure started with the meniscus on the back side. 3 months. You see the line of force here. After 12 months, space closure was almost finished. Then at this stage, we removed the lingual wire and lever arm and apply clear liner. Can you see the clear liner here? Wearing clear liner for 10 months, we can get this result. No bracket was needed for treatment. And for the retention, she was anterior open case. We used rubber elastics 9 times for the preventing open bile relapse. If we treat open bile case, I'd like to recommend this type of retainer. This is after 12 months of retainer. Before and after. And superimposition. The desired tooth movement will take place. So let me summarize my presentation. Lever arm mechanics make it possible to control precise tooth movement in labial and lingual orthodontics, and combined use of meniscus and lever arm mechanics can achieve an efficient and aesthetic tooth movement. Thank you very much for your attention. Actually, we have an announcement. We had a long day today.
Yeah. pretty long day.
Okay, have any question? Did you get to know about the lateral mechanics? Yes, it's very simple, and it's an extension of a single tooth biomechanics in applied to segmented arch movement. Okay, and so we are gradually moving on to segmental movement next tomorrow, and then total arch movement. And then gradually we're moving on to the next level or next step of the biomechanics. Hopefully you will enjoy the whole intensive. Are we set?
Yeah.
You're happy? You're tired? Very tired? Maybe another class of 3-4 hours? Now, we need some refreshment. We have you have some refreshment? No? Well, we're going to start the reception at 6:30. It's very close by, alumni hall, which is the next building, right in front of the. So this side, if you get out of the. So take the elevator down to the first floor. No, not second floor. Okay, don't miss it. Take the elevator down to the basement, first basement, and then step outside. There will be our residents lining up, guiding you to the way to show you the way to the alumni hall. Then you reach the